Greetings and welcome to today's webinar on social empowerment and ART adherence among adolescents living with HIV. My name is Jennifer Pearson, and I am a technical advisor at the AIDS-Free Project. Before we begin today's presentations, I'd like to quickly review the Adobe Connect environment and set a few norms for today's webinar. Today's webinar has 3 presentations, followed by a discussion period, during which our speakers will address your questions. Within the webinar environment, please make use of the Q&A box on the bottom right side of your screen to share your thoughts, note your questions, or ask for help with sound during the presentation. Questions you ask are only visible to you, our presenters, and technical support. If you are experiencing difficulties, our technical support will respond to your question privately. We will collect your questions for our speakers and will save them for the discussion period. It is great that we are able to connect so many people from so many places today, but your experience may vary based on your internet connection and computer equipment. I will briefly go over a few troubleshooting steps if you have technology challenges today. A few troubleshooting tips. If you lose connectivity or cannot hear, close the webinar. Re-enter the meeting room in a browser other than Google Chrome by clicking on the webinar link provided. You can also use the Q&A box to ask AIDS-Free Tech for assistance. If these troubleshooting steps are not successful, please rest assured the webinar is being recorded and the link to the recording will be posted to the AIDS-Free website after today's event. Questions that don't get answered during the Q&A sessions will be compiled after the webinar, shared with our presenters, and responses from presenters will be shared with participants. To get us started, I will now turn it over to our moderator, Lorraine Schur.
Right. Good morning, everybody. It's really wonderful to be here. I'd like to welcome and thank everyone for participating. I'm a professor of clinical and health psychology based at University College London, and today's webinar is organized by AIDS-Free, the Coalition for Children Affected by AIDS, and For Children, an amazing group who are all working in the interest of children. We have gathered today an international thought leaders group to share some very preliminary and exciting results emerging from studies in both South Africa and Uganda, detailing different pathways that uncover the connections between economic opportunities, cash plus care, which is becoming a really important concept, social protection that we all know about, and HIV treatment outcomes amongst adolescents living with HIV. Essentially, I want to give you some very brief background and then introduce us to our wonderful speakers. As we all know, adolescents are actually the lowest adherent group when we look at studies of all age groups. A very good review of this by Huddleston and Kluver, and it seems a group that we really need to focus some attention on, based on the idea that AIDS is actually the single greatest cause of adolescent death, according to UNAIDS statistics. So this is a current and very demanding problem. And curiously, there is really an absence of evidence-based interventions. There's been 3 systematic reviews by Huddleston and Kluver, McPherson, and an early one by Riemann, none of which were able to show any exhaustive interventions. Now, what are the ramifications? Why does it matter? Well, I think we need to understand what are the drivers. If we understand the drivers, maybe we'll have some better provision and targeting of interventions. And what could they be? So there are lots of them. Structural drivers, behavioral, psychological, very practical. Maybe there are medical drivers, something in the environment of the adolescent. We know stigma is a driver for adults. Is this true of adolescents as well? Just the side effects of medications may be a driver, or fear of taking the medication, fear of going to the clinic. A whole host of misunderstandings and miscommunications, poor service, very common, or very practical issues like drug stock out and clinic access. With all of those many considerations, adolescent non-adherence is really important. Why? Well, if an adolescent does not adhere, the first problem is one of treatment failure. Their treatment for themselves will not be effective, and viral resistance may well develop. Now, when an adolescent has viral resistance, we have a transmission risk to others. We know that if early treatment and viral load is undetectable, transmission risks really do go down. So it's not only a risk to the adolescents themselves, but to all their partners. Within poorer contexts, we know that second-line treatment is extremely expensive and often not available. And cost-efficacy studies do show that it is much better to put many people on first-line treatment than have to use second-line and salvage treatment, especially in cost-restrained environments. So the cost escalation is a real consideration. And of course, for the individual, if treatment fails, if viral resistance occurs, and if the HIV is not contained, illness and death are on the cards. So with that kind of background, I think we're all keen to hear from our first speaker, who is Professor Lucy Kluwer. Lucy is based at Oxford University and jointly with the University of Cape Town. And Lucy is going to discuss cash and care. Welcome, Lucy.
Thank you very much, Lorraine. And Lorraine may have to take over my talk. I've had a baby 2 weeks ago, and if you start hearing yelling in the background, Lorraine will take over. Just to start by saying that this work that I'm presenting is actually a huge team effort, and some of the team members are on this call, but there are many others who are still slogging away in the townships of the Eastern Cape collecting data and who can't be joining us today. And really what we're going to talk about is some of the potential for social protection and adolescent adherence. And this is a study which has which was developed with a whole range of partners and funders, and here are many of the really key ones. And you can see that the South African government has been particularly strongly involved, as well as colleagues at USAID, PEPFAR, and UKAID. Really, the two key points to think about with this, because Lorraine and I were sharing very similar data and literature background, was that there are a huge number of HIV-positive adolescents in Southern Africa. And although at the moment it's around 70% who are perinatally infected and 30% postnatally infected, that is shifting over time, and we will be seeing more postnatally infected adolescents as infection rates rise and as PMTCT hopefully starts to take more and more effect. But really what we wanted to try and understand is whether social protection, particularly cash plus care, could help reduce the worryingly high rates of non-adherence that we're seeing amongst adolescents. And really, you know, at the point of starting to test, we didn't have a strong sense. There was no literature, there was no evidence to suggest whether this might work, apart from some really interesting work which has been done in Ethiopia with USAID and colleagues at the World Food Programme, which was showing the provision of food and financial support to adults with HIV was increasing rates of adherence. And that's really encouraging that we may see the same for adolescents. So this is a new study. We've just finished collecting the first year of data collection. It's a 3-year study, and we're in the midst of the second year. And really it's in two parts. The first part is an in-depth qualitative part led by Dr. Rebecca Hodes at UCT, and she and her team have spent around 2,000 hours following and observing and spending time with positive adolescents and observing what happens when they're in their life and in clinics. What I'm going to talk more about this morning is a longitudinal panel study which is alongside that, which is interviewed just over 1,500 adolescents, of whom 1,000 are HIV positive and of 500 are neighbor adolescents. Essentially, when we interviewed an adolescent, we would interview the kid next door or another kid at home, and really as a stigma prevention measure. But this has also given us a really interesting control group of negative adolescents. And essentially, what we tried to do, which was a bit different, most studies will interview teenagers who are in the clinic, who come into the clinic. Because we were interested particularly in non-adherence and dropout, we started with the clinic list in 53 clinics, so every clinic in a health district of the Eastern Cape, which is one of South Africa's poorest, most deprived provinces. We went to every clinic, went through the big file rooms, found every file of every adolescent who had ever initiated ART, and then went to their homes to try and and we will be following them over 3 years. We developed with teenagers, with our teen advisory group of positive adolescents, kind of cool designed tablet-based programs and questionnaires, which we hope help make them feel comfortable and happy to talk about very stigmatized things like non-adherence. And you can see on the right the crucial question, who is your favorite sports player? And the question is, how did we do in terms of sample representativity? How much like the sample of ever-initiated adolescents did we get? Well, due to an enormous amount of hard work by our field teams, 90% adolescents were found and interviewed. And you can see that there were small numbers that we didn't manage to reach. As we go back in the second year, we are going back to the ones who refused and the ones we were unable to trace to see if we can find them again. But 90% seems pretty good. And when we look at who our sample are, we see, and you can see there the red lines are the HIV positive and the blue lines are the HIV negative adolescents. We can see high rates of maternal and paternal orphaning, around 45% in the positive group. Very high rates of poverty in both groups, but not statistically significantly different. And in our HIV positive group, around 65% knew their own HIV status. So particularly many of the younger ones hadn't yet been told that they were HIV positive. When we look at rates of self-reported non-adherence, we start seeing some very worrying patterns. So in the past week, 36% of adolescents report that they've been non-adherent. In the past weekend alone, that was 25%, and in the past year, 52%. When we look at detectable viral load, which is a sort of biomarker often used to look at non-adherence, we see around 60% have a detectable viral load, a very high rate. And I suppose a real question that we asked ourselves is, how reliable is self-reported non-adherence? And this is something Fred will, I'm sure, talk about as well. It's a tricky question because viral load is also potentially unreliable. It could be due to other reasons. So what we did was we did two things. The first was that we really worked with adolescents and piloted to improve the way we talked about non-adherence with them. So for example, if you say to a teenager, did you not take your meds last week? They will, of course, lie to you and say, yes, of course, I took my meds. But if we tried to make it a kind of story about adolescents who'd really wanted to take their meds but had struggled to do them, and that seemed to increase the willingness of teenagers to talk about this. But we also wanted to statistically check whether it was reliable or not. So what we did was we compared associations with biomarkers of opportunistic infections like TB and oral thrush, and then also looked at reliability against detectable viral load, and controlled, as you can see below on the left, for a whole range of demographic potential confounders. And what we found was very high correlation. So it looks like self-reported non-adherence is very strongly associated with biomarkers, and we hope then that it should be a relatively valid measure. So we started to think first about what might be some of the structural drivers of non-adherence. And really this is very initial data, and I hope you'll all bear with it because over the next 6 months we hope to get much more detailed data. But even when we just start to look at missing appointments and missing pickups for medication, controlling for sociodemographic and illness covariates, we start seeing some structural factors which suggest that social protection may be important. So when we looked at a range of predictors of non-access, we see that lack of travel money and attending the clinic on your own, not having a caregiver come with you to attend clinic, were both strong predictors of missing medication pickups and missing appointments. When we looked at a range of predictors of non-adherence, past week non-adherence, we find that 3 types of violence very strongly predicted non-adherence. That was physical abuse in the home, abuse by a teacher at school, and exposure to domestic violence within the home. I mean, this is going to be presented at the International AIDS Conference and at the Children and AIDS pre-conference, the Coalition Children and AIDS pre-conference in July. What we see when we looked at marginal effects, which is a way of testing whether cumulative impacts of structural drivers might be affecting non-adherence, just looking at violence, we see very clear effects of that. So, for example, an adolescent with no violence at all has around 30% non-adherence, whereas an adolescent who's being physically abused at home, has violence at school, and is exposed to domestic violence has a 66% chance, a more than double chance of non-adherence. So the next thing that we looked at, and this is a paper that's going to be published in the International AIDS Conference Special Edition, Equity Edition of AIDS Care Journal, we asked ourselves what are the potential social protection factors that might be improving this problem of non-adherence. And we looked at a whole range of cash on the left and care on the right variables. So in cash, we looked at government cash transfers, food security, school access, school feeding, and access to clothing. And in care, we looked at whether the adolescent was accessing a HIV support group, a sports group, a choir or arts group, whether they were receiving positive parenting, warmth, and praise, and whether they were receiving good parental supervision. That's like monitoring the adolescent, knowing who their friends are, having a time to get home in the evening. And underneath, you can see that we controlled for pretty much everything you could imagine for, to really robustly check. And we put all of these factors in together to check whether they were functioning independently of each other. Unfortunately, or fortunately, because South Africa has done so well in the government cash transfer rollout and school feeding, the numbers were very high, and so we had to exclude those because they weren't statistically viable. Too many kids were getting them, but that's, I think, a good thing overall. So what did we find? You can see that the factors in red are the ones that came out independently significant with everything else. And we can see that what came out significant predictors of improved adherence to ART was food security, access to at least 2 meals a day regularly in the past week, access to HIV support group, of which only 13% of adolescents were, and having good parental supervision. Positive parenting, warmth and praise, unfortunately didn't seem to make a difference, but good monitoring and supervision did. We then asked the same question as we did with the predictors of poor adherence. We said, if we join those together, do we get better effects? And really excitingly, we do. So if you look to the left, you can see that adolescents who have neither a support group, nor food security, nor good parental monitoring, 54% of them had been non-adherent to ART in the past week. If we look to the far right, we can see that adolescents with all 3 of those social protection factors is reduced to 18, only 18% of them have been non-adherent in the last week. And that seems a really promising effect of social protection. And just very briefly before I finish, I wanted to mention some additional analyses that Ilona Tosca and working with Rebecca Hodes have been doing, which is really thinking about whether social protection might help reduce unsafe sex for HIV-positive adolescents. Now, Ilona asked about the last time that the adolescent had had sex and whether it was protected or unprotected, and worryingly, 28% of adolescents, HIV-positive girls, have reported unprotected sex at their last time of intercourse. And if you look at the qualitative evidence, you see a real range of things that adolescents talk about, predicting why they struggle to disclose to their partners and why why having safe sex is actually a really difficult and complex social issue for them. But Ilona really wanted to also ask about social protection and whether that did make a difference. And what we see here again is another really encouraging set of predictors which suggests that we really can do something with social protection. Now these predictors were slightly different to the ones for adherence. Good parental supervision came out strongly again, but access to school and attending either a free school or a school that they could afford also came out very strongly. And so particularly did getting positive and respectful care within the clinic, within the sexual health clinic. And we see, if we look to the left, that an adolescent girl who gets none of those, 50% of them, half of them had unprotected sex the last time they had intercourse, whereas adolescent girls had good parental supervision, school access, and respectful clinic care, had only 8% had unprotected sex the last time they had intercourse. So really do watch this space for more analyses like this, and we'd really value any suggestions of further things that we should be or could be looking at that would be useful for practitioners and policymakers and programmers. And I'd like to end by saying that this has been an enormous team effort. You'll see just some of the incredibly hardworking teams' names here, and they are incredibly hardworking 4x4 vehicles, one of which here is stuck very firmly in the mud. Thanks very much, everyone, and look forward to your questions. Bye-bye.
Thank you, Lucy. That was really very interesting. Please, everybody, could you continue adding your questions for Lucy in the Q&A box for our discussion session at the end. And now I'm going to move over to the next presentation, which is from Professor Fred Siramala and Professor Laura Bermudez from Columbia University. Over to you.
Yeah. Thank you so much, Lorraine, and thank you so much for everyone who is tuning in. Thanks, Lucy, for that lead presentation. Our presentation is going to be co-presented between me, Fred Siramala. I'm a professor here at Columbia University in the School of Social Work, and Laura, who is our doctoral student here at the School of Social Work. So Lucy gave us a very good kind of lead into a quote I want to begin with. And as you can see from this quote, it's from a teenager living with HIV and AIDS in Rakhine, one of the participants that we worked with as we were beginning the study. The study I'm going to present is funded by NICHD, but the views are definitely those of us researchers. So this participant says, and I quote, "When I first started taking ARVs, I learned I had to take them with food, else I would become nauseous. They also made my appetite too high. I felt hungry all the time. I tried to eat more than usual, but the hunger I felt during that time was too much. I just didn't have enough food to satisfy my hunger, so I stopped taking my ARVs." So this is extremely important, especially in light of the free ARVs now being given out to all young people in Uganda for as long as you are below ages 16. So the question always was, are young people not adhering because they don't have access to ART, or are there other reasons? So with free ART, why still are young people, adolescents, not adhering? And so our research question, the question that guides our study, is in light of now access, free access, hopefully with provision of ART, do economic factors still influence adherence to medication among these young people who are living with HIV? So we use the data that we are presenting today comes from a study called SUUBI+Adherence. It's in 6 districts in Uganda, southwestern part, in 39 clinics, and we have 2 study conditions. We have a study condition where young people are given and their families are given an economic empowerment opportunity, which constitutes a savings account, financial management training, and access to micro enterprise training. And then the other group really receives information around adherence. We use cartoons and that sort of stuff. So we have these two study arms. The treatment arm has 20 clinics and the control arm has 19 clinics. And these were all matched at baseline. So our inclusion criteria was the person had to be HIV positive, they had to live within a family, and they had to be prescribed ART. They had to be on ART, and they had to be enrolled in one of the clinics that we are partnering with. So the slide next really just gives you the distribution. We have 356 young people in the 20 health centers that are in the treatment condition, and 344 in the control condition. The randomization was done at the clinic level. All the young people within a given clinic receive the same intervention. So we have a total of 702 young people. So without going in detail about the numbers, Lucy gave us great numbers. What I wanted to highlight here is the fact that the area where we are working has a slightly higher prevalence rate than the rest of the country. So this is the Rakai Masaka region with a 9.8 prevalence rate in regards to HIV. So we use different measures for us to be able to measure adherence, which is really very common, because like Lucy clearly pointed out, the question always is, are self-reports as biomarkers as accurate as things like WISE pills or memo cards and that kind of stuff. So in this study, we are using a whole range of measures, and in the slide that I'm showing right now, we see that at baseline, over 75% of the participants reported perfect adherence when we look at their self-report, and then 64% report perfect adherence when we use the WISE pill device. The WISE pill is a device which is like a mem. It registers an opening each time a participant opens the device, and we assume that each time a participant opens the device that they are taking a medication. So they open and close, so we are able to track that. And then we also draw blood, and from viral load, we see that 59% of the participants were perfect adhering. I want now to move on to the actual findings, and these will be presented by Laura.
Thank you so much, Brad, for giving us a great overall picture of the broader SUUBI+Adherence study. What I'll be talking about now is the examination of the pre-intervention baseline data that we did to look at equity and adherence based on social and economic factors. In this particular paper, our dependent variable or primary outcome analysis was self-reported adherence based on the number of days a respondent had missed at least one dose of medication in the last month. And our independent variables fell into 3 different categories. We categorized them as assets and employment, which looked at variables such as material assets, financial inclusion, and caregiver employment. also food security, which, as it sounds, is about food security, and then social equity, which covered things such as school enrollment, distance to community resources, and social support. The analysis we used for this paper is using logistic regression. We looked at bivariate comparisons, meaning that we looked at each of the individual variables in isolation to see what their influence was on adherence. And then we also looked at composite measures. We made these composites of food security and social equity so we could see what the cumulative effect of food security or social equity would be on adherence. So this is the table of our results, and I'll just let you know how to look at this. Using logistic regression, the second vertical column down is the OR. It's called the odds ratio. Basically, in the way that we set up the variables, anything over 1 means that for adolescents that had higher values in the variables on the left, they were more likely to self-report perfect adherence. Anything under 1 had an inverse relationship, which means that adolescents who had higher values in these variables were actually less likely to adhere. And this is a little bit counterintuitive. We have a couple of these, so we'll talk about that. The other thing to note is that those results that are bolded and with a star means that they're statistically significant at the traditional 0.05 value. Those with the little cross mark fell between 0.05 and 0.1, which is sort of the statistical gray area. Some people report it, others don't. We've basically listed it as something of interest. So as you look down at the results, you'll see that material asset ownership by a family statistically significantly was associated with higher rates of adherence. So those who had more assets were more likely to adhere by a factor of 1.69. Where alternatively, if a child's caregiver was in the formal labor market, they were actually less likely to adhere. And this is one that falls in the statistical gray area, but something that's a bit interesting and something we could potentially talk about during Q&A. If you look at available cash savings, participation in a formal banking institution, or material housing value, all of these are over 1, showing that adolescents with greater values or greater advantage in these variables were more likely to adhere. However, this was not statistically significant. When you look at food security, it's the same, all over 1. Adolescents with greater food security more likely to adhere, but the only ones reaching statistical significance or close by was number of meals per day. And then when you look at social equity variables, the first looking at school enrollment, this one was not statistically significant, but if it were, it had an inverse relationship, which was rather interesting. Children enrolled in school were actually less likely to report perfect adherence. As you'll go down, you'll see proximity to community resources, all over 1, all showing that the closer you are to the resources, the more likely you are to adhere. However, the only one statistically significant was the proximity to the health clinic. Electricity in the home was at 1, which is this neutral. It means that adolescents were no more and no less likely to adhere based on availability of electricity. And social support for adherence, again, over 1, more likely to adhere if having social support, but not statistically significant. These results are just the results in the text form, so I'll bypass them since we looked at the chart. And then when we look at the multivariate regression, which is our composite indices with our controls. I'll start first with the controls. While these were primarily meant just as control factors, there was one that actually turned out to be statistically significant in its influence on adherence, and that was gender. Females in this age group of 10 to 16 were actually more likely to adhere by a factor of 1.73. And that's something interesting we'll talk about in the discussion as well. When we come to our composite indices, assets and employment was statistically significantly associated with adherence. So cumulatively, those with greater advantage in material assets, financial inclusion, et cetera, were more likely to adhere. Food security, not statistically significant, but if it were, had a bit of an inverse relationship. It was less than 1. So those with more food security were less likely to adhere. It's a bit counterintuitive, but we have some thoughts on that for the discussion. And then social equity also showed greater than 1, more likely to adhere if greater advantage in the social realm cumulatively, but not quite statistically significant. So that brings us to the discussion. We have some implications for policy and practice. We believe that economic and social determinants of adherence should be given due priority when you're designing and developing programs targeting youth with HIV. Even in contexts where ARV rollout is free, we believe that there are certain factors that are affecting uptake of ARV medication. So when we're looking at our study and the results, we feel that interventions that aim to improve financial assets, foster financial inclusion, or provide geographically closer HIV treatment services are ones that may offer promising returns for greater uptake of ARV among this population. And then when we talk about our implications for research, you know, this paper was done purely quantitatively. We were just crunching numbers. It would be very interesting to find out qualitatively how do adolescents interpret their sense of advantage or disadvantage in economic and social realms. Also looking at gender, girls were reported to have more optimal adherence than boys. How does this change when you age out of the 10 to 16 age group? As females marry and have familial responsibilities, does their adherence change? And what are we doing to target adolescent boys? Does this need to be better, more targeted for better uptake by this group? Looking at food security, again, you know, wasn't statistically significant, but it did show that those with greater food security were less likely, were less likely to adhere, which is very interesting as it's kind of counterintuitive. We thought, could perhaps this be illustrative of a family having a limited set of resources and having to decide whether or not to buy food or to have money for transportation to a clinic to pick up their medication. Perhaps in this instance, they chose to buy food, which would show, if they're filling a survey, that they are food secure because they have food at the time, but are non-adherent. So that is our thought on that. Also to note is that we were using measures that were available measures of food security from prior SUUBI questionnaires. They were food security questions kind of tossed into a multidimensional poverty assessment. It wasn't a very detailed or long validated scale of food security. So that is another thing to note. Looking at school enrollment and stigma, that was one that also had an inverse relationship. You know, could school enrollment participation does this have an inverse effect on adherence? And is this because children have a fear of status disclosure or social ostracism? That's something to think about moving forward. And then just lastly, when we talk about this concept of equity, it's a hot term, it's very exciting, but there are not really standard core measures of what it means to achieve equity, particularly in this area of adherence. If it's possible for the community to come together to develop a core set of equity measures, is this something that we could put into multidimensional screening tools for youth to determine those that may have predictable challenges to adherence moving forward, and then strategically design our programs to reach the most vulnerable youth? And just lastly, that wraps up our paper, but we wanted to give you a little sneak peek about what we're doing with the larger SUUBI+Adherence study. We do have some data coming in from Wave 2, thanks to our colleagues at the Rakai Health Services Program, Gertrude Nachigosi and others. We have viral load comparisons and we have WISE-PIL comparisons, and while the data is mixed, the trends are basically showing that those involved in our treatment group who received the financial inclusion, financial asset intervention are becoming more likely to adhere after 2 years than those in the control. And so these are our acknowledgements. We've worked with such a great group of people, and so we'd love to acknowledge all of them. It couldn't happen without everyone's hard work. Thank you very much.
Right, wonderful. Thank you, everybody. Those are just two really excellent and thought-provoking talks. Now I would like to look at the time that we have for discussion, which is really quite good. So could everybody please type questions for our presenters into the Q&A box, but we already have a whole load. So I'm going to try and get to as many questions in the time we have remaining. Right, so the first question that I'd like to raise was one where somebody has asked Lucy how you got to your 90% response rate, and is this something that they can learn from for their research?
It's a great question, and thank you. I think that the answer is sheer determination of the field team. Essentially what we did was we went through, it was quite difficult because many people come to the clinic with a false name or address, and there's high levels of migration and movement. But essentially what the field team did was they went into villages and townships, traipsed around trying to find kids. We had to be quite vague about what the study was about. In the communities, the study was presented as a general health study for adolescents in communities. We couldn't specify HIV because we didn't want to stigmatize families where communities didn't know. But they literally sat around, they asked people, they went to schools, they went to churches, and they just kept going until they found almost every child. And if you're determined enough, you really can find people.
Great. Now, we have another question that's come in from Jason, which is, if we think social protection, in particular cash transfers, are an important ingredient to support adherence, and the South African child grant coverage is so high within the sample, then why do we think non-adherence is such an issue? And I think I'm going to ask Lucy to comment on this in terms of South Africa, and maybe a brief comment on the state of cash transfers from Fred and Laura.
Thank you. Well, I was actually going to ask Lorraine for her thoughts on this, because when Jason asked the question, my heart sinks because I always think I'll be able to answer it. And the truth is, I don't know. One thing that I read your question, Jason, was that, you know, when you look at the findings, but also at the study in Ethiopia, we saw that having enough money to get to clinic and having enough money to pay for food seems to be very basic for the social protection requirements. And the South African Child Support Grant is 200 Rand per month for the whole family, and that wouldn't be enough to pay for those two basics. So it could be that although the grants are there, it may not be enough. But Lorraine, what do you think? Because this is a really good question.
Well, for a start, we know that adherence isn't perfect in rich countries, so clearly it's not the magic bullet. I think it's necessary, but not sufficient, and that's the answer. So in just looking at Fred and Laura's data as well as ours, just such drastic poverty must be the background that we have to take into context. And clearly, cash transfers is a great big step, clearly from these two data. But my view would be it's a great step, but it's not sufficient. Laura, Fred, what are your thoughts?
Yeah, could you repeat, please?
I think the question, which is really quite a challenging one, is that if cash transfers are an important ingredient, and South African child grant coverage is really so high now, why do we think non-adherence is such an issue? So really, is cash transfer going to solve all the problems?
Actually, that's an excellent. That's an excellent question. As all our presentations indicated, is no one factor. I think it's a combination as and cash transfer may be of the many that we adhere. So I mean there could be and above the other reasons why adolescents are not adhering. So I mean it's a tough question what about in the context. I don't know whether Laura has.
Yeah, I would agree. I mean, I'll look at economic strengthening. Fred said cash transfer child savings, one that build more long-term assets, and cash transfers serve as the immediate stopgap measure for social inclusion at the time, where other economic do have an eye on sort of long-term financial inclusion and long-term strengthening. So there could be some questions in there as to which are more effective at time, and maybe it's for a course. You know, you start with cash and you try to move into something that's more long-term, and maybe that's the way.
Okay, so let's move on and try and pack in some more questions. We have one where somebody has asked, was there any opportunity to look at effects if other economic variables beyond overall poverty and access to conditional transfers in these adherence scenarios? So this person asks for things like employment or job training. Did anyone manage to look at those and what did they find?
This came from Michael, didn't it? Michael Ferguson from Aspires. Michael, it's a great question, and the answer is no, we haven't looked at it yet because our kids were too young. Very low rates of employment in that age group. We only went up to 19 this first year, but we will be looking at it in the coming years. But I think it would be great for Fred to be able to answer that as well, because Fred's SUUBI study is really, which you're familiar with, is creating this kind of really exciting economic empowerment program, and it would be great to hear a bit about that. So Fred or Lauren would love to hear about that.
Thanks, Lucy. Our kids probably are younger than Lucy's, so we haven't looked at that. Our kids are 10 to 16-year-olds at baseline, and hopefully by this is a 5-year study. Hopefully by wave 5, we may be able to address that question. So the Michael, it's definitely a great question, but at this stage we haven't addressed that question because these kids are young, and the oldest is 16 years old, and in fact the 16 age group is even smaller. We have a bigger number if you look at the distribution in the 10 to 13-year-olds.
Okay, thanks. Heidi asks that if she's understood correctly, the first presentation said that there was a correlation between social support and adherence, but in the second, there seemed to be no significant effect. So she asks, has she understood that correctly? And if so, can you both comment on that?
Shall I answer first? Heidi, it's a great question. You know what? We haven't looked at social support more generally. We've looked at being in an HIV support group, which and we said that they had to attend at least monthly. We did try and look at kids who attended weekly to a support group, but only something like 3% of kids attended weekly. So we found about 13% attended monthly, and that did improve adherence. But general levels of social support is a really good, I don't know why we haven't looked at it yet, but we should have, and we will. From my recollection, when we looked at it briefly and initially, it was predictive of adherence. Fred, what did you find?
Hi, this is Laura. Yes, that's an excellent question, and she is correct. In our particular presentation, we had social support, which was one particular variable under the larger social equity composite. For social support, the way we looked at it was a question to adolescents that asked them, do they have social support for adherence specifically? And in our findings, while the results were over 1 and did show that those with higher levels of social support for adherence were more likely to adhere, it was not quite statistically significant. So that is the way that our results shook out.
Okay, Georgia asks if you could very briefly summarize the findings of the financial education savings intervention to young people and its effect on adherence.
Yeah, we did that in the last slide, but we we can go over it again. I think the implications, am I right? The implications for policy, do you?
Yeah, I think she was asking what are some of the preliminary findings of our treatment, the effect of our treatment in Wave 2, and perhaps maybe this question came before I provided the last slide, but there are some details in the last slide that show that those who are adolescents who are participating in the treatment group, who are receiving a financial intervention, are showing trends toward greater adherence after 2 years in Wave 2. Thank you for pulling that up. Thanks so much. And this is a 5-year study, so we'll have more data moving on. These are just preliminary results, and it'll be very interesting to see how this trend continues.
Hello?
Great.
Okay.
We have loads of questions pouring in. Somebody's asked a little bit if you could just tell them about how the cash transfers work in South Africa. I think that's an enormous question, but maybe if you could just give them a minute or two.
Absolutely, and again, I'm going to ask Lorraine for input on this. I mean, really, South Africa's leading the way in Africa with cash transfers to the poor, and the child support grant, which is the vast majority of the cash transfer that is delivered here, is around 200 rand per month. It's generally shared out within the whole family. It goes to the main caregiver of the child, and that's almost always a woman. And it used to be mainly coming in cash, but now it's primarily delivered into a bank account, a sort of temporary bank account by the Social Security Agency of South Africa. And I would recommend, if you're interested in this, to look at Michael Sampson's work, and UNICEF have done some really excellent work on the child support grant. And if you just Google that, you can find a whole load of really valuable information, particularly on some of the health benefits of that grant to children. Lorraine, is there anything I've forgotten? Lorraine and I did all these analyses together, so I'm relying on her.
Well, I think that covers it very, very easily. South Africa has just become, giving of grants has just become routinized. In some countries it's still in a kind of research environment where you have conditional and unconditional. And I think there's a big move that unconditional makes life very much easier and reaches the most vulnerable. Okay. We have a series of questions that all are on the same thing, which are really about the clinic visits. And maybe both teams could answer the questions. If I was summarizing, several people have asked it. Basically, what could the clinics do? The clinic visit seems to be an issue here. And would you suggest more frequent visits or better quality visits? What would you do?
Fred, do you want to have a go at answering first? I'm happy to, but I keep going first.
No, that's fine. Yeah, definitely. One of the measures that we have in our study is the use of what we call clinic records. And so, in Uganda, in the area where we are working in the 6 districts, there are what they call adolescent days. So adolescents come in for their medication on specific days, and so our research team goes on those days and tries to do the pill counting and also interact with the youth during that time. It also allows us to get to know which youth are there, which youth didn't show up, and why. So that's in terms of that's in terms of our research assistants visiting the clinics. And also what that does, it allows us to find out what youth are consistently not turning up, that maybe we may need to go and visit them at their homes. Our research team has done a great job that they know every child, out of the 700 kids they have reached every child's home because, of course, we give out the WisePill devices. And so the question of clinic visits, I don't know whether it's about the process, but the way we do it in Uganda, in the 6 districts where we work, we rely mainly on the adolescent days. But we also have unannounced visits to the young people themselves, to their homes, where we just show up to do pill counts without telling them that we'll be here. So we have combined both clinic visits with research assistants, where they go to the clinics, and then we have also the visits to the participants' homes. I don't know whether that was your question in regards to clinic visits, or you wanted. Yeah. So Laura can add. Yeah.
I can add as well. I think from the study that we did, it did show the statistically significant finding was that those who had greater proximity to the health clinic were more likely to adhere. So we do feel like distance is an issue, and that there has been a lot of emphasis in mobile clinics with testing and counseling. If that sort of emphasis is also placed on adherence for this particular population with the use of mobile clinics, then perhaps that would also be helpful.
So that addresses the distance part, yeah.
Great.
Okay.
Oh, sorry.
Go ahead, Lisa.
I just wanted to say this is such an important question, and Ilona Tosca's work has shown that in terms of sexual health, it was hugely important, the kind of treatment that came from clinic staff. We are actually in the middle of doing a really quite complicated analysis where we're looking at a whole range of clinic level factors, ranging from what kind of clinic, whether it's a pediatric clinic or a main hospital clinic, also looking at questions like how the staff treats the adolescents at every point in the clinic, what kind of staff they see, whether they see a doctor or a pharmacist or a nurse or a counsellor, and what's availability, whether there are stockouts. It's a big question, it's a complicated question, and we should have the findings within the next month or so. So could I ask, if it's a question that really interests you, do drop me an email in about 2 months' time when we should have really clarified those results. We're not certain enough of them to report them yet, though. The good news is the South African Department of Health are working very closely with us on this and are very determined to make changes in their clinic provision based on these findings. So that's really encouraging.
This is an easy question. So I want you to clarify the age and how you define adolescence. I think that was mentioned in some of the talks, but anyway, if we could if we could just have that clarified.
Sorry, we should have said 10 to 19 we started with, although of course as we keep following them they'll get older.
Yes, and in our particular study, our cohort was 10 to 16.
Great, and I think that's really reassuring because we see a lot of research where they've got a very loose definition of adolescence, which I think clouds the picture. I've seen studies where it includes people up to 24, and then the worst offender, who actually calls it adolescent study or youth, it's got up to 35 years of age. And I think if we are interested in the particularities of adolescence, I think sticking with the UNICEF definition of 18 or younger is going to really help researchers in this area. So that was a great question, and I think we all need to work on that. So we've got loads, and we're running close out of time, but I'm going to try and pack them in. Sarah has asked, are you looking at the impact of more frequent quality clinic visits? And if when the clinic is structured in a certain way, that addresses young people's needs, if this has an impact on adherence. So really building on your comments about the clinic, what's your views on frequency?
It's a great question. We hadn't looked at it, and we will. I think what we need to distinguish, though, is whether they're being asked to come more frequently or whether they're going more frequently, because they're two different things. Yes, you're right. We should put it on our list of things to look at. Thank you.
Pamela asks, and this is for both groups, do you have a challenge with consent from parents of the participants? And if you did, how did you deal with that?
That's a great question. Shall I answer first, and then Fred and Laura, you can answer? We from very, very high rates of consent. We only had 4% in the whole sample who didn't consent, but you're right that most of them were parents and not adolescents. And really, parents didn't, the ones who didn't consent was often either because they were very scared of, you know, they were feeling very stigmatized, very worried, and were very scared that anything would be identified. And once we'd interviewed some other kids in the street, that often went away. But the other reason that we sometimes do get parental non-consent is when the parent is abusing the child, or when there's something going on at home that they don't want people to be finding out about, particularly if they're dealing drugs or doing something illegal. And so that's quite difficult to deal with. The other reason why we had non-consent was when people had extremely large dogs, and our interviewers were too scared in case of getting bitten by the dogs, and I have no idea how to deal with that, and any advice would be very gratefully received.
So I first of all, just to go back on the clinic question, sorry, I may have misunderstood it, so thanks to Laura for clarifying. So in regards to the consent of yeah, we do, this is the research, so we do get consent from the parents, but in terms of the numbers, so our inclusion criteria is that a kid must be aware why they are taking ART. And what we found, over 100 families who came with their kids, they had not, although they consented for their kids to participate in the study, they had not disclosed to the kids why the kids were taking medication. And so they wanted our team to be the one to disclose to the kids so that the kid could enroll in the study. And as you all know, disclosure takes time. You have to prepare the child. You cannot just disclose, at the time of the interview. So we did not. I don't recall whether we really had any parent who said, "I don't want to be part of the study." The parents and the kids that were not included was purely because of non-disclosure. Most of the kids were not included and were on ART had been, and quote-unquote, lied to, and they were being told that you are taking medication because of a constant headache or because of, you have ulcers. And so these kids didn't know that they were HIV positive. And it wasn't the responsibility of the study wasn't designed that it would be the responsibility of our team to disclose. So we asked the parents to be the ones to take time with their kids and eventually disclose to the kids, and then after that they could be enrolled in our study. So to answer, the short answer is all the parents that were invited consented, but many were not included because the kids didn't know why they were all taking their medication, and since that was part of the inclusion criteria, we couldn't enroll them.
Thank you for that. That's really an interesting issue, particularly on what the effects on those who didn't know. Fascinating. And in Lucy's figures, we also saw there were a group who didn't know their status. Sadly, we've come onto the hour, and although the question, I had to use the scale bar to get the questions now, I know everyone will try and answer them. So before we wrap up, we'd like to again thank all the participants for giving their time. We had over 100 attendees from all over the world, and their expertise today from our 3 speakers. So in the next few days, you will receive an email with a link to today's recording. And before we close the room, I really want to encourage you to just take a moment to fill out the poll questions below, as the feedback really helps us to improve future webinars. And from my point of view, I really want to thank the people who made this possible. The AIDS-Free group have been amazing, the Coalition, and For Children. This is just such a fabulous type of dialogue, and I'm sure everyone will agree with us how important these webinars are. Thank you, everybody.
Thanks, everyone. Bye-bye.
Goodbye.
Yes.